So I just want to take a moment to ask the representatives from British Columbia to please put up their hand and wave who they are, because what I'm about to share with you is over a decade of work that we've done in the province of British Columbia that I've had the pleasure of being involved in for, in fact, 13 years. So I just want to start with a little story. In 2010, Canada participated in a national forum around mental health, the Kirby-Keon Commission, that some of you might remember. And I was invited by our Assistant Deputy Minister of Health to present at a national forum the results of a province-wide coordinated survey that we had undertaken in British Columbia of all inpatient psychiatry units, asking patients for their feedback, as well as detox, support recovery, and withdrawal management. 102 locations across the province with about 35,000 respondents. And I was very proud of the work that we had done in engaging patients, family members, in validating the survey questionnaire by looking at a gap analysis, et cetera, using the themes from the Kirby-Keon Commission. And so I was excited to present the results, and we had some very interesting findings that were worthy of presentation. And at the conference, there was a patient partner present. And the patient partner made a statement after my presentation, and she used a quote from Professor Irving Selikoff from New York University, in which Irving Selikoff, who was a respirologist who had worked against big industry and government around the asbestos catastrophe, where people were becoming sick with lung cancer as a result of asbestos, and he coined the statement, "Statistics are people with the tears wiped off." And I went home that night thinking I had transitioned my career from a clinician specializing in working with young adults with neuromuscular disorders as a therapist to collecting data and presenting numbers. And I literally couldn't sleep that night because I felt that I had really, betrayed my reason for going into healthcare, that I was truly translating. But in fact, what I learned as a result of that was that, in fact, at the heart of every single data point that we collect when we do patient-centered measurement is a person who has taken the time to give us their feedback about their healthcare experience, a person who has needs and wants and is in a relationship with us, often as a vulnerable individual who requires our services. So my mission became, what could we do to translate the data, much like Heather's described, into sound bites that would make the information more acceptable and actionable. So what I'm going to share with you are lessons that we've learned from over a decade of patient-centered measurement in the province of British Columbia. And I just want to do a shout out to the fact that I've heard already today, and I very well understand, and we understand in British Columbia, that the work that we do of the provincially coordinated sector surveys, scientifically rigorous, large-scale surveys, is only one way that patients provide us feedback. So as a clinician, when I look my patients in the eye and I ask them to provide feedback, whether it's in a structured or an unstructured way, is another way of collecting feedback. And that can be done on an ongoing basis to give us timely information. And as an OT, whether I use goal attainment scaling, whether I use the Canadian Occupational Performance Measure as a structured way of interacting with my patients, I'm also collecting feedback. Whether I'm running focus groups, there are many, many ways. The focus of my work now and the work of our steering committee is our provincially coordinated work. So, we have a number of different lessons that I think are relevant to what we're trying to accomplish today. But I've broken them into two different areas. The challenges that we have faced and what we've learned in some of the that was Freudian, success factors related to how do we translate information to promote understanding of the patient-centered measurement that we collect at the level of the clinician and the leaders, so much along the lines of what Heather's discussed. But also, then how do we promote action on that? And so I've got examples at a system level, at a local level, and at a patient level. So we know that there is a plethora of literature out there, and I was a Picker Institute Fellow for 2 years. And there's a lot of literature out there that talks about what do patients need and want when they need health care. But the challenge is, if we're doing patient-centered measurement, what in fact are we measuring? Are we measuring patient satisfaction, patient experience, patient-reported outcomes, patient-reported incidents? What in fact are we measuring? And they're all important and good things to measure. What we've hung our hat on, rightly or wrongly and open for criticism in the province of British Columbia, is that we've evolved from looking at just global ratings, and I shouldn't say just, because they are important and we continue to collect them, and we use them to do correlations to help us determine importance. But a global rating that says on a scale of 1 to 100, on a scale of 1 to 10, from excellent to poor, tell us how satisfied you were. It's very important information, but we've decided it's not enough. So we also collect measures of acceptability, and we ask questions about what actually happened to you. And we use information that we have. So if you should be getting information verbally and in writing, as Heather says, about when to start, stop, and continue your medications, did you get the information in writing and verbally about when to start, stop your medication? So measures of acceptability. But we've also taken the bold step, and I'm very proud that our work continues to evolve, to look at patient-reported outcomes. So also asking patients about their health-related quality of life, and specifically their views of whether the clinical outcomes that were promised were actually delivered. So after more than a decade, we've heard from more than 1 million different people, but I also want to let you know that we have the records with identifiers that are linkable to all clinical and administrative databases of 17.9 million people who've had encounters in 13 different sectors and subsectors in our province. So this is one way to look at the work that we've done. This is another way. And you'll get these slides so you can look at them in more detail. But again, to Heather's point, when we get our deputy minister and our health authority CEOs to say we're going to do surveying in a sector, it's with a commitment that it is a baseline and that we must repeat that sector again over time. So that the needle. The other thing, I can't go backwards, is that these are very large scale. So I started with the mental health example of 101 facilities, 111 emergency departments in the province, 80 acute care hospitals. They're huge, large-scale surveys with a budget of between $1.7 million. So one of the issues is resource allocation. Do we have the funds to do that kind of work? But so the data arrives. We do this fabulous work, the data arrives, but why is all of this great data not consistently being used? I didn't know Heather was going to be doing her presentation. I put this together, but it is a line. So this is the value chain of the work that we do in British Columbia. Everything from survey selection and or design, data collection, data processing, reporting, and we are a well-oiled machine. Lillian, put up your hand and wave. We've got amazing project managers that just, make this happen. But look at sharing results and action plannings in a different color. Initially, believe it or not, our steering committee said, that's not your job. You don't need to do that, because if you finish the work that you have to do with reporting, the people will just take that information and they will embrace it and use it. You don't need to do the work of the dissemination, and you don't need to support the action planning. One of the things I wanted to add is that we actually have a triple mandate. We started with a dual mandate, and I think this, again, is really important and aligns to the message that I heard Heather say, and that is we always develop our sample plans for both accountability and local level improvement. We develop our sample plans at the location of service, the unit, the service location, and then we do statistical weighting to roll up the results to the health authority and the province, even the facility. So from the unit to the facility to the program to the health authority, the health service delivery area, and the province. Now, because of SPORE, we've been very fortunate, and if you haven't already done it, you need to look at SPORE as a source of funding. We just got $3.75 million over 5 years. If we commit that every data point that we collect is going to go into a repository for research purposes and linkable. Okay, so challenge or example number 1, supporting clinicians and leaders to understand our survey results. And so we're shifting the balance, right? We're shifting the balance from collection to sharing and reporting. And Michael Murray, who many of you may know from the University of Toronto, now retired, he used this quotation. I think it's also really important. Only when data has been analyzed, interpreted, and presented in a manner that makes it understandable and useful to others does it become information. So we did a qualitative project in the province of British Columbia. We interviewed 152 people across the province, policymakers, clinicians, leaders, etc. And what they told us were things I've heard today. The data's not timely enough, the burden of the data, you're giving us way too much information, and there's no accountability. So our response was faster, better, easier to read reports. The solution was we changed our reports to include real examples from real people about the real stories. We combined qualitative results with quantitative results with annotations. So these beautiful run charts we took, which we'd been presenting, we added to those annotations. And again, Lillian's in the room. She supported this work. We made observations. What does the data point this month show you? We then asked prompting questions, and then we added a qualitative comment from a patient that aligned to the question. Just another example. Here's another example of a storyboard, a one-page summary of the results that highlight key variables, but again have comments embedded. And here's an example of one that's under construction that we're developing now, moving to the infographic. If you haven't seen this at the British Museum, you can Google it and go on. This is the story of Every Woman and Every Man, a big project that was done in the UK where they tracked the story of two people's lives, a generic man and a generic woman from birth to death, based on the medications they had taken over the course of their lives. It just shows stories and other visuals really help. So measurement is crucial, of course, but as Don Berwick says, but please remember that our measurement will mislead us if we forget that behind every data point is a real person, if we forget the stories. So just a couple of other examples, promoting system-level improvement. We conducted a province-wide workshop. Instead of handing off the results, we brought people together, and we looked at the fact that I feel really strongly that making changes for one patient, making changes in one location will not improve the healthcare system as a whole. So we brought together people from across the province to hand off the results, look at what's relevant, important, where performance was poor. And Kim Stager's in the room from PHSA. Here's a link for you to look at. We just won the provincial program won the 3M Quality Award. Lillian's in the room again, developed a mini survey toolkit to take out of the 50, 60, 80 questions on a survey, a handful of questions, and help at the local level to use those questions, a workshop, a whole curriculum around doing that, an Excel database that they can easily put their information in. And then we've got projects underway at the point of care using tablets and supporting clinicians to be able to use an innovative way of collecting data using both PREMS and PROMs and supporting clinicians at the point of care. So after 13 years, we're still learning and evolving, which makes my job really continue to be exciting. Been there, done that. We've moved from patient satisfaction to patient-centered measurement, and our mantra is PREMS plus PROMs equals better together. From presenting only numbers to numbers and stories, from data collection and reporting only to supporting action, from data collection for QI and accountability to making linkable data available to researchers with our SPORE funding. What we're still grappling with is changing from a sector location of care focus to asking patients about their experiences across their episode of care, where our data shows the continuity across transitions in care, collecting real-time versus retrospective, supporting collecting point of care versus province-wide, and responding to social media. So Irving Selikoff said statistics are people with the tears wiped off, and I say statistics can be people without the tears wiped off. If you want to read more, there's an article.